Welcome and good afternoon, and thank you for joining us for today's presentation on advancing health equity for individuals with intellectual disabilities. My name is Dr. Joan Reed, and if you heard a screech in the background, that was my granddaughter Malia saying hello. I am Dean for Diversity and Community Partnership at Harvard Medical School. This webinar is part of Harvard Medical School's Office for Diversity, Inclusion, and Community Partnership, Equity, and Social Justice Initiative. This initiative was established to address issues related to health disparities, social determinants of health, leadership in health systems, health policy, and other areas affecting vulnerable populations. ESJ, or Equity and Social Justice events, focus on 4 areas: history and context, culture and environment, health disparities, and leadership and skills development. This series is sponsored by the Harvard Medical School Office for Diversity, Inclusion, and Community Partnership, and the mission of DICP is to advance diversity and inclusion in health, biomedical, behavioral, and STEM fields in ways that build individual and institutional capacity to achieve excellence, foster innovation, and ensure equity in health locally, nationally, and globally. DICP support the career development of junior faculty, trainees, and students, identifies and trains leaders in academic medicine and health policy, and provides programs that address crucial pipeline pathway issues. For those of you who are joining us by Zoom, we have a few housekeeping notes. The chat is not available. Your microphones will be muted, but you can use the Q&A to pose questions to panelists. This webinar is being recorded and will be posted on the DICP website. And now it's my pleasure to introduce Dr. Alden Landry. Dr. Landry is an emergency medicine physician at Beth Israel Deaconess Medical Center, Associate Professor of Emergency Medicine, and Assistant Dean in the Office of Diversity, Inclusion, and Community Partnership at Harvard Medical School. Dr. Landry?
Thank you for the introduction, Dr. Reed, and thank you to everyone for joining us this afternoon. Good afternoon. Before we get started, I want to share with you an important statement from the Dean of Harvard Medical School regarding Harvard's statement on mutual respect in public discourse in the foundational university-wide statement on rights and responsibilities. We are a community that expects freedom from personal intimidation, harassment, hate speech, and intrusive violations of our workplace. As an academic institution, we must protect the rights of our members to learn and to study, teach, and to research. In short, to ensure that our students, faculty, postdocs, and staff can continue the important work at the core of our mission as a medical school. Accordingly, we must balance our dual commitment to free expression and mutual respect so that we can all work together to expand human knowledge and deepen understanding. The slide before you lists the rules of the road for us to be mutually supportive as a community. We ask you take a moment to review it and follow up with any questions you may have in the comment section, as well as in the evaluation of today's program. Now, on to today's topic for the webinar. We will be discussing issues faced by individuals with intellectual disabilities and their ability to access healthcare and the health equity issues that exist. It was not intentional that this presentation is happening during Autism Awareness Month, but it was brought to light by the many calendar updates that I get and our 2 panelists that are going to be joining us as they talk about the work that they do, talk about the communities that they serve and the healthcare that they provide, and really share with us some really important health equity issues that individuals with intellectual disabilities must deal with as they encounter our healthcare system. So I'm going to introduce our 2 panelists. Dr. Sabrina Sargato is a developmental behavioral pediatrician in the Department of Developmental Medicine at Boston Children's Hospital. She is one of the attending physicians at Boston Children's Hospital Down Syndrome Program and an instructor in pediatrics at Harvard Medical School. She specializes in the assessment and treatment of children with neurodevelopmental disorders, including Down syndrome, intellectual disability, autism, and ADHD. Her research interests include autism in individuals with Down syndrome, regression in individuals with Down syndrome and attention deficit hyperactivity disorder. She is currently the site PI of an NIH-funded study for clinical trial to evaluate treatment in ADHD in children with Down syndrome. Our next panelist is Dr. Anshul Sharma. She is a double-boarded double board certified developmental behavioral pediatrician in the Department of Developmental Medicine here at Boston Children's Hospital as well, and the Advocating Success for Kids program. Additionally, she serves as an instructor in the pediatrics, an instructor in pediatrics at Harvard Medical School. Her research interests are focused on sexuality and access to sexual health resources for individuals with ASD. And she is currently the PI for a pilot study exploring knowledge and interests related to relationships for adults with Down syndrome and intellectual disabilities. And so thank you to our speakers for joining us. And I'm going to start with you, Anshul, because I have a couple of questions, but really I want to make sure that we have a level setting discussion. I think it's important for us to all be on the same space when it comes to definitions. So can you give some standard working definitions that we could use not only in this presentation, but also in our clinical care going forward?
Sure. Thank you for having us. So the first thing to talk about is what is an intellectual disability? And the definition has evolved over time. It has changed with different iterations of the DSM that has come out. The DSM is the Diagnostic and Statistical Manual of Mental Disorders. It's what clinicians use when making these diagnoses and understanding the criteria that an individual must meet in order to have a certain diagnosis. So intellectual disabilities traditionally were solely based on a person's IQ or intelligence quotient. So that's based on cognitive testing or an IQ test that was done. And it was very much hard cutoffs with different numbers that you would get on that on the score on your performance on the assessment. Over time, the definition has changed and it has taken into consideration not just limitations in cognitive functioning, but also limitations in adaptive functioning. So that's your day-to-day functioning. And also it has to occur with an onset at an age less than 18. So there's different categories of intellectual disability. There's mild, moderate, severe, and profound. And in order to meet criteria for this, you have to have testing that shows cognitive impairment, but also working with families and with the individual and understanding how their day-to-day functioning is occurring and the level of support they need to get through their basic functioning and basic skills. And so that's how we generally make this diagnosis. I think that it's important to mention that intellectual disability was previously called something different and terminology that we don't use anymore. So it was previously called mental retardation, and we don't use that terminology now. But just to give context for people who may have heard that terminology and don't know how that relates to ID or intellectual disability. The other thing that I think is important is that when we're thinking about, well, what kind of IQ cutoffs are we looking at when considering an ID diagnosis? Generally, it's IQ less than 70. So average IQ ranges from 85 to 115, and most individuals generally fall within that range. But for individuals whose cognitive functioning falls below or equal to 70, they generally are then considered to have some form of an intellectual disability. The one other thing that I wanted to mention is that ID can co-occur with many other diagnoses. It can co-occur with an autism spectrum disorder, with ADHD, which is attention deficit hyperactivity disorder, Down syndrome, and many other genetic conditions. So it's not exclusive that you have to have only ID or only one of these things. You can have both things co-occurring. And because you mentioned that it's Autism Awareness Month, I also think it's very important to clarify that there is a difference, a distinct difference between ID and autism. And so autism is a diagnosis that really captures, and it's a spectrum. So there's a wide range of functioning that can occur with different children and young adults who meet criteria for an ASD diagnosis. But generally, it's challenges that individuals have with social communication skills, as well as restrictive and repetitive behaviors. So you may not have cognitive impairment and therefore not have ID, but have autism, and vice versa. You may have ID and not have those social communication vulnerabilities or restrictive and repetitive behaviors that you see with an autism diagnosis.
Thank you for the clarification. I think it'll be helpful for us as we go through the rest of this discussion to really sort of be level setted with those definitions and the clarity that you provided. We often think about this work or these diagnoses at the childhood or pediatric level. This means that these individuals with these diagnoses are interacting with our schools and the school systems. What does this mean for learning at this critical stage of development?
That's a great question, and I think a very important question. I think we often want to think about the level of support and advocacy that we can provide not only to the kids, but the families that we are supporting who are being affected by these different diagnoses. And we are lucky in ways to be in Massachusetts. There, we have a lot of laws in place to support the education of young children who have intellectual disabilities and or other disabilities. It's important to do a little bit of history talk right now. So back in the 70s, in 1975, President Ford had put into effect a law that was Education for All Handicapped Children's Act, which is now called IDEA, Individuals with Disabilities Education Act. And what IDEA affords to young children who are engaging with the educational system is allowing them to have access to the curriculum in the least restrictive environment and affording them opportunities to learn academic skills, but also to foster their social and emotional functioning in academic settings. And so through IDEA, there's different things that are supported. So for children who are less than the age of 3, they can receive services through early intervention. And then once they turn 3, they can engage with the public school system and receive supports in the academic setting through either a 504 plan or an IEP, an individualized education plan. So you can go kind of either way depending on the level of supports that a child needs. I think the most important takeaway here is that it has to be catered or curated to the child, the specific child, and what their specific strengths are and what their specific weaknesses are. And that's why it's really important to do individual assessments. And I think that this is often challenging when there are long wait lists and also disparities in how much people know about what they're entitled to access and what services and resources are available for them. So I think it's a really important question to bring up and for everyone to know and to continue to advocate and promote information and awareness about this because all children have a right to access curriculum and education. And what research shows is that the earlier we engage children with any type of diagnosis, the earlier we provide them with services, the better their outcomes are likely going to be. So I think this is a very critical time for intervention, especially less than the age of 3, and making sure that we have those people seeking out those evaluations and even self requesting and advocating to get services for their children is very important.
And I'm going to take a quick aside because I want to dive into what you were just mentioning a little bit more. So you talked about early diagnosis, but oftentimes those diagnoses don't come up until, in some cases, elementary or even middle school or high school. And so can you talk about the importance of just engaging in those resources? You mentioned self-advocacy, but then also how those resources can follow a student longitudinally throughout their educational learning.
Sure, that's a great question. I think an important question when you talk about intellectual disability, because we are very rarely diagnosing a child who's less than 7 or 8 years old with an intellectual disability. Oftentimes, what happens is either they're being diagnosed with something called a global developmental delay or some sort of delay, whether it's cognitive delay, speech delay. You're seeing that this child is not making hitting the same milestones, making the same progress as maybe some of their peers or other children in the family. So families have some knowledge that something's there that we need to get our child evaluated. The challenge is that many places that do evaluations and make diagnoses have long wait lists. So what can you do in the interim? Well, you can call early intervention and have your child evaluated without anyone placing a referral. You can do that on your own. And yes, there are wait lists for early intervention as well, but this at least gets people aware and especially families aware of where validating what their concerns are. You know, does the child truly have a speech delay? Is there a motor delay, gross motor, fine motor delay? Is there a social communication delay? Are there behaviors that are being seen that are outside the realm of what we would expect for a child of that age? And then for the longitudinal question that you have, oftentimes, more often than not, children who qualify for early intervention will qualify for some sort of supports through the school system. And so there should be and I say should be because it's not always perfect, but there should be a pathway that once a child turns about 2 years, 9 months, around that age, to start filling their family to start filling out paperwork to transition so that there isn't a gap between early intervention abruptly ending when they turn 3 and then transitioning to the public school system. And you can qualify for an IEP not necessarily having a diagnosis of autism or global developmental delay or an intellectual disability. The school does their own evaluation, and if they see areas where a child needs support, then they should, and most of the time do, offer supports and services for that child. Not all children need robust services through an IEP, so some will qualify for accommodations through a 504 plan, but not all children get the services that they may need or that their family feels like they need. And so there are a lot of supports in the community for advocacy with schools, as well as with other organizations, to kind of support families as they go through this process, because it's quite overwhelming and there's a lot of layers to it.
Thank you. And I have a couple other questions. We'll dive into those towards the end. But I think that was a great introduction into this discussion around educational resources. We started with education, but we often turned a blind eye to another important part of development, which is sexual development in individuals with intellectual disabilities. Can you talk about the importance of sexual health education in this space?
Yes, favorite topic of mine, so I can talk about it forever. But I think that we have to look at a child and a young adult as a whole, right? And it's not just sexual health, right? It's building relationships, being able to engage with those around you, because as you go through life, you know how important having meaningful relationships are, not just sexual partner relationships, but friendships, relationships with family members, relatives, and some people who may not be blood relatives, but people who become your family because of how much they mean to you, how much they support you. Young children who have intellectual disability, global developmental delay, autism, et cetera, are vulnerable to having challenges with developing long-term peer relationships. And so we want to set them up for success there. That's one part of it. Another really important part is victimization rates. There's a lot of research there. I shouldn't say a lot. There's more research out there for individuals who have autism than those who have intellectual disability. There's just not enough there for individuals with ID. So I will talk a little bit about the research that exists for those who have autism. And there are disproportionately higher rates of sexual victimization with individuals who have ASD versus their neurotypical peers. So this is definitely an area that we need to be focused on, and it's a population that we cannot let fall through the cracks when it comes to this information. The AAP, which is the American Academy for Pediatrics, has put out policy statements. They put out one in 2016, they put out one in 2021, saying that there needs to be evidence-based and developmentally appropriate curriculum developed and disseminated and shared so that people feel comfortable talking about these topics, because oftentimes it's that discomfort that providers have, that families have, that parents have, of bringing up these topics with their children. But I think what we want to do is we want to set these young kids up for successful futures and successful adult lives. So I think that it needs to be integrated, not just into the educational curriculum, but also in terms of their medical visits with their providers. It should not fall by the wayside. I mean, I can talk about this for hours, but I think the takeaway is that more work needs to be done. And that's what part of the work that I'm doing with Dr. Susan Feja and Dr. David Pantalone in the Feja lab at Boston Children's Hospital is developing this type of evidence-based curriculum. And we have a lot of partners in the New England area who are interested in this field as well. So stay tuned. I think there's going to be a lot coming on the horizon. And I think this is gaining more and more buzz as time goes on. But I think it's a really important area that needs to be talked about, because transition to adult care, which I think, Dr. Sargato will talk about, includes this point, but many other points that need to be advocated for.
And so my last question for you is really a pivot. We've been talking about this from, definition in resources and also from a patient perspective, but I want to flip this and have this discussion from a provider perspective. We talk about these issues related to diversity, equity, inclusion as part of medical education, and we talk about the importance of thinking about the patient as a whole. However, I'm not sure if medical education is really caught up to speed with really engaging future healthcare professionals, medical students becoming doctors, trainees in this space as they transition from trainee to faculty member, or even continuing medical education. We just really haven't sort of embraced these concepts around caring for individuals with intellectual disability, intellectual disabilities. Can you talk about why it's important that we all learn about how to care for individuals with intellectual disabilities?
Another thing that I think we both can talk about for hours here. I think it's hard to summarize it into just like one or two key points, but I think the takeaway here is that there needs to be competence and sensitivity to all individuals around you, regardless of what we're talking about here: race, ethnicity, developmental disability status. You there, especially when you're working in the medical field, you have to understand how all of these things interact with each other. Just because an individual has an intellectual disability doesn't mean that you don't ask them all the questions you should. But it also means that there has to be certain nuances in how you're approaching this patient. You have to have the knowledge that, well, if this person has an intellectual disability, they may have a guardian with them. They may have somebody with them who's helping making, their decision making. And you have to think about these things. If you don't have this awareness, there's going to be a disservice in how treatment is being provided, and also in the questions that you're asking. Are you asking developmentally appropriate questions to individuals when they're coming into the emergency room? Are you using terminology that they're going to understand? It just leads to healthcare disparities and worse outcomes when we don't have that knowledge and awareness. I think that it's really important to include this kind of throughout and diffusely, not just in medical education, but in all education. I think being aware that there are people with disabilities and differences around you, embracing those differences and understanding that everyone is entitled to living their, fullest life, and they're entitled to go to the same places you're going, to have the same experiences you're having, maybe just perceiving them in different ways. I mean, these are lessons that I try to teach to my children. These are lessons that I think that schools should be including in their curriculum. Yes, we have separate classrooms sometimes for certain children, but there should be opportunities for inclusion and exposure so that everybody feels comfortable. I mean, I remember just a very quick anecdote. I remember in residency training, there was a young child with autism that came in. Everyone knew that I had an interest in this field. I have, personal family history of individuals with an ID and autism, and I just felt more comfortable around young children with this diagnosis. And they would always just say, okay, why don't you go see this patient? Because there's this inherent discomfort in asking certain questions and acknowledging certain diagnoses. And I think moving away from the stigma and embracing people for who they are, and allowing ourselves to ask questions. It's okay if you don't know everything about a certain diagnosis or how the child presents, or what's the right thing to say, but ignoring it is not going to be the answer here. So that's just my 2 cents about that.
No, and I think you make a great point. Especially, we have to recognize that we're sitting at Harvard Medical School with Boston Children's Hospital, and we have a plethora of resources. And I think and this again will be a question or a conversation for later, we have to recognize the amount of privilege that we have, and the fact that we have individuals like the both of you who have specialized in this area and caring for this patient population, whereas not every community has someone who is versed and trained in caring for patients with intellectual disabilities. And so we are certainly in a position of privilege because we have the resources here, but our rural communities may not have this. Our other underserved communities may not have these levels of resource. So I think it's important for us to recognize that if individuals are going out and practicing in the different corners of our country, they need to be able to prepare to take care of all patients, not just patients that they're most comfortable with. So thank you for that. So I will open it up to questions for you, Dr. Sharma, towards the end. If you have questions for Dr. Sharma, please put those in the Q&A, and we'll be sure to come up and go through all of those questions. But I want to turn to Dr. Sargato. Building upon our previous conversation, we're talking about caring for individuals with intellectual disabilities, but that's only one component of an individual's overall health. Can you talk more about some of the health issues that we often see that either occur in concordance with individuals with intellectual disabilities, or in addition to having an intellectual disability?
Thank you so much for having us today. This is a great topic. So individuals with intellectual disability often have other health conditions. So they may suffer from metabolic or congenital or chronic health conditions that we need to be aware of. So an example would be seizures. So seizures are highest in the most severe or profound ID and can affect up to 50% of people with intellectual disability and concurrent cerebral palsy. So other conditions could include congenital heart disease. So for example, for children with Down syndrome. Others include dental caries, endocrine abnormalities like hypo or hyperthyroidism, reflux, hearing and vision problems. Another one is obesity. So overweight and obesity are more commonly impact youth with ID than their typically developing peers. Why is this? So it's because they may have risk factors that predispose to obesity and being overweight. So these include, they can have altered diets, they can have difficulties moving, for example, so physical impairments. They can have underlying genetic syndromes that predispose them to obesity. Another one are sleep disorders. So sleep disorders in children with ID may be due to learned behaviors, but it's important to think about, could it be related to other health conditions that they may also have? So for example, if you have a child with Down syndrome, up to 50 to 75% of individuals with Down syndrome at some point are an increased risk for obstructive sleep apnea. So that's something that you need to think about. Or is it medication related? Another thing is that if ID has a genetic cause, this should be identified and this patient should be evaluated for comorbid conditions that are known to be associated with specific syndromes. So for example, Down syndrome is the most common chromosomal disorder occurring in 1 out of 700 babies. And most individuals with Down syndrome will have intellectual disability. So as I say that, it's important to really remember that these individuals may have varying abilities. They may have varying social skills, communication skills, language skills, and adaptive skills. That half of them may have congenital heart disease, and a lot of them, so this is actually more common than we thought, up to 75% will have hearing problems, 60 to 80% will have vision problems, they may have thyroid problems. So this really impacts their learning and their ability to be independent at some point. Another thing that is beginning to come up are neurodevelopmental disorders and mental health, or NDD. So NDDs, we now know, are approximately 5 times more likely in children and individuals with intellectual disability. And more often than not, these are unrecognized, and they severely impact learning, function, quality of life, and their independence. So Dr. Sharma talked about one of them, and it is Autism Awareness Month. So one of them is autism spectrum disorder, and it commonly can co-occur with intellectual disability. About up to 28% of children with ID can have a co-occurring diagnosis of autism. Another one is ADHD, or attention deficit hyperactivity disorder. So children with ID may have comorbid ADHD. And when you think about it in this way, you have to think that their inattention, their hyperactivity, their impulsivity is above and beyond it's incongruent with their developmental level. So now we know that ADHD is actually common in children with Down syndrome. So the typical prevalence of ADHD in typical kids is about 8%. For children with Down syndrome, studies have shown it can be up to 40 to 44%. But a lot of this is unrecognized because either physicians are not recognizing them, and they're attributing a lot of the behaviors of ADHD to intellectual disability. So it's really important to recognize this. Mood, so depression and anxiety are important to identify because they're treatable. And one thing I would like to talk about is that the more severe the intellectual disability, the less communication skills a person has, the more atypical the presentation. I'll say, when we think about depression, we're thinking about somebody who's sad, who may withdraw. But for somebody who doesn't have communication skills, it may present as aggression. It may present as anger or irritability. And then there's self-injurious behaviors. So self-injurious and aggressive behaviors occur commonly in individuals with intellectual disability who have limited communication when they are experiencing anxiety or stress or pain or depression. So it's important to think about these things. The takeaway message, I think, is that comprehensive care for individuals with intellectual disability needs to be a multidisciplinary approach. So physicians, providers, therapists, teachers, family members really need to talk to each other and collaborate, and also come up with a coordinated plan to not just deal with, say, learning issues, but overall see the person as a whole, so that they can address their needs.
Thank you for that. That was really comprehensive. I think, you know, we've been having this discussion and we talked about education. We talked about sexual health awareness with Dr. Sharma, but we have to extend this discussion outside of the educational system and the healthcare system, because individuals with intellectual disabilities don't live within a bubble. They don't live solely in the healthcare system. They're in our communities. Hopefully they're a part of our workforce, and hopefully they get to experience all the same things that we do in this country. Can you talk about the systems that are in place to support these individuals, to help them to have the ability to maintain an appropriate level of independence? And then also what resources we should be investing in from a policy standpoint, from a government standpoint, to support these individuals?
That's a really great question. It's an important question, especially as we're going to talk about transition later. So the integration of individuals with ID into our communities, our workforce, our broader societal experiences is really important that they occur in an early age to foster their independence and for equity. So a concept that's related to this and is often talked about is what we call neurodiversity. So what is neurodiversity? Neurodiversity describes the way that people experience and interact with the world around them. It's the idea that we can do this in different ways. There is no right way of thinking, learning, behaving, and these differences are not viewed as deficits. They're just differences. So this movement, this term was coined back in the 1990s, actually, by an Australian sociologist. Her name was Judy Singer, and she wanted to promote equality and inclusion. Having said that, having kind of talked about that, there are systems that are in place at both the federal and state level to help individuals with ID gain an appropriate level of independence. This is really important for, I think, their providers to know and for their families to know. And it's important to know this early on. So we're going to talk about laws. One of them is the Americans with Disabilities Act, or the ADA, which prohibits discrimination against people with disabilities in several areas. So employment, transportation, public accommodation, communication, access to state and local government programs. What does this look like in real life? So for example, somebody with not even ID, somebody who is deaf may need a sign language interpreter during a job interview. An employee who has diabetes may need frequent breaks, scheduled breaks, to monitor their blood sugar and to make sure they have time to eat. So it basically affects all areas of a person's life. So we talked about, so Title I is about employment. Then there's Title II, which is about state and local government activities. And there's also public transportation. So if you've gone on the T, right? So you'll see accommodations made for individuals with disability. Title III, I think we're more aware of that, because this issues guidelines for buildings to be accessible. So these are your bathrooms, your hotel rooms that are handicap accessible. And Title IV is about telecommunications. Right now we have closed captioning enabled. So that's under Title IV. Another law, which I think is very interesting, is the Rehab Act of 1973, as amended, or in short, the Rehab Act. So this prohibits discrimination on the basis of disability in programs conducted by federal agencies that give financial aid, or in people looking for federal employment, or in federal contractors. The third one, Dr. Sharma talked about, the IDEA. So the IDEA is bigger than just about education. So the IDEA actually in 2004, there was a change to it that mandated transition planning for all individuals with disabilities or all students who have an IEP from K to 12. So what does this mean? So the purpose of this is to facilitate the students' move from the school now to post-secondary education. So this includes employment, independence in the community, and community participation. So the IDEA 2004, as we call it, is a federal law. So it mandates transition planning at 16. Massachusetts in 2008 passed a law that decreased, basically it made transition planning earlier. So if you go to any school in Mass, their transition planning starts at 14. If a child has an IEP, then at 14, their IEP team has to use what we call a transition planning form. So what it does is it talks, that form, it basically enables the IEP team to talk to the parents and to the child and see what is their vision, what are their goals for after post-secondary education, and how can we help them achieve this goal. So I think it's really important for parents and providers to know that, because like Dr. Sharma said, ideally this should be happening, and it is happening, but sometimes parents don't know, oh, this is really important. I really need to engage with this. And it starts as early as 14. There's also the Mass Rehab Commission. So a lot of my patients don't realize, or the MRC, that they can access the MRC as early as 14. So the Mass Rehab Commission basically requires, it's required to promote coordination of educational services with the school, starting from 14 to 22. So what does this mean? So remember we talked about the IDEA 2004 and the transition planning. So for example, a child with intellectual disability, the school is tasked with then teaching them the skills that they need, such as, for example, communication skills, right? Money count, like being able to count money, math skills, right? Reading, writing. The Mass Rehab Commission is the one that you need for pre-employment transitional services. So for example, job exploration, having internships and actually going into a job and having somebody help you and train you to prepare for that job, and counseling on what you can do after you turn 22. And the last one I want to talk about is the Chapter 688 referral, or we know this as the Turning 22 Law. So this is important for students who may be very impaired. So it stipulates that a student receiving special education, who because of the severity of their needs may require continued disability-related services after school, and they shall be offered specific transition planning. There are other things we can talk about, like personal care attendants from Mass Health and adult foster care. We can talk about this all day, but I'm sure we can talk about it afterward.
Thank you. And it seems like there's a lot left to be discussed in that space, really, just to helping individuals with disabilities to intellectual disabilities to be included. And I think that's really a key discussion point for this entire talk. I want to make a transition because I'm an emergency physician, and one of the issues that I often run into when I'm caring for individuals with intellectual disabilities is related to guardianship. So can you talk more about how the medical system can do better to help individuals with intellectual disabilities, either to maintain their own independence, specifically in the healthcare system, or to ensure appropriate supporting guardianship for these individuals?
That's a great question. I think let's start by talking first about what is guardianship. So guardianship is a legal way to protect children and adults who cannot care for themselves make decisions that are in their best interest, or they may need help managing their own assets. It's important to preface this by saying that the process for guardianship is really different in every state. It comes back to the idea about their capacity, the idea of capacity. So capacity is the ability to make informed decisions that are in their best interest. This has implications for rendering care. So, for example, in the emergency room, can a patient consent to a procedure? Do they understand, the procedure? Do they understand the risks and benefits? In the clinic, can your patient tell you what their medications are? Do they know what the medication is for? It can be as simple as, are they able to communicate pain? Are they able to tell you what's wrong? So the process of guardianship begins with a petition to the court to create a guardianship. In Massachusetts, you have two. You can have full guardianship, and you have limited or partial guardianship. So limited or partial guardianship just means they limit the decision-making to certain areas. So for example, a guardian may elect, I'm just going to make decisions about financial and medical things. So this can be tailored to fit a family's needs. I think the need comes in the realization that the process of guardianship, it can be really challenging for a lot of families. This is something I think, capacity, independence, transition, all families are thinking about this, but not all families actually will engage or are talking to their health provider about it, right? So in Massachusetts, since we're talking about individuals with ID, they're going to need what we call a clinical team report, a CTR. The CTR needs 3 people to sign that report. So one is a physician who's evaluated your child and knows everything about the medical history of your child. 2 is a social worker who's going to talk to the patient and to the family. And the 3rd is a psychologist who will do their own evaluation. So when you're coming to, say, Boston Children's Hospital and we have an entire team, that is something that can be done efficiently, right? But think about if you're not plugged in to something like a resource like BCH. You have to find those 3 people, and then they have to coordinate to sign this document, and there's a time component. So everything needs to be done within 6 months before a child turns 18. And so that all has to be done in that time frame. And then the family has to petition the court. So there's so many steps. I mean, just talking about it, you realize, oh my goodness, there's so many steps. If you don't know what to do, it can be really overwhelming. So I think it's really important for families to start talking to their healthcare provider, to start accessing the resources around them, DDS, the ARC, there's so many resources. If they're with Boston Children's Hospital, for example, we have what we call, I'll talk about this more, I'll show them. This is called our guardianship, transition folder, right? So it basically breaks down what's a complex task into specific timelines and specific things for a family to do. So once a guardianship is obtained, it's important to have that in the individual's medical record and to have a written plan of care. I want to take a step back and kind of talk about the alternatives to guardianship, because I know that's going to come up. So supported decision-making is something that right now we're advocating for, and it's in the process, but it's still does not have enough legal background, in Massachusetts. So it's a beautiful thing where it allows an adult with disability to make his or her own decisions with the help of trusted supporters. So right now we have advocates who are trying to pass bills so that supported decision making can be something we can use here in Massachusetts. 2 things that come up in the ER. One is healthcare proxy. So healthcare proxy is a legal document, and it basically, you and I can have a legal proxy, right? So healthcare proxy. Basically, it allows an adult to choose a trusted person to make the medical decisions for me when I can no longer do it. What's important to remember is that it's a legal document and the individual must understand it. So if an individual does not understand what's on the document, then that healthcare proxy is not valid. And that is something that we have come across, in situations like in the ED. The other one is the durable power of attorney. So again, this is a legal document that allows a trusted person to manage somebody's money, property, business affairs. But again, a part of this is that the individual, when they sign the durable power of attorney, they have to understand what they're signing. They have to understand the content of that legal document. I think that the medical system definitely will need to do better to ensure that if somebody needs guardianship or if somebody needs help in making decisions, that they're never in that place where, you know, where they're now, for safety, it's now a risk to their safety, or they need to have something done and they can't have it done because they can't give consent. It's like this cycle. And I think that we need to do better to ensure that guardianship, if needed, is completed in a timely and efficient manner.
So I have one more question for you before we turn it over to Q&A. And so just remember to use the Q&A function, and I will be monitoring those, and I'll present those to our panelists after I ask this last question. So you held up the form, the folder, and talked about the transition to adulthood. Can you talk a little bit more about caring for individuals as they go from the pediatrician and the specialist that you all have at Boston Children's Hospital to an adult healthcare system that is not as tightly integrated as what you may have at Boston Children's? So what are some of the gaps that happen, and how can we ensure that there is a smooth transition from care at the pediatric level to care at the adult level?
That's a great question. Again, it's huge. So transition, when we talk about transition, it's transition, everybody transitions, right? It's particularly challenging for children with intellectual disability. So transition, think about it as transition at home, like gaining independence at home. Transition in the community, gaining independence in the community. There's, Dr. Sharma talked about school. So there's, you know, educational transition. But then there's also healthcare transition. So healthcare transition is the process of changing from a pediatric provider or model to an adult model of healthcare. And I think one of the challenges is that it's a very different model. So a PEDS model is a very family-centered, multidisciplinary model, and the parent plays a significant part in this decision-making, right? Once you go into adult care, it's more problem-focused. When you're talking about specialists, most pediatric specialists will collaborate with each other. They talk to each other. It's multidisciplinary, right? For adults, each subspecialist is they work on their own, and it's isolated. Another one is the role of the primary care provider, whoever it may be. So in the pediatrics world, even though they're the medical home, the pediatric specialist may not need to involve them. Like, they'll let them know what's happening, but they make their own, you know, they continue with their recommendations. A lot of times in the adult world, the specialist only makes recommendations, and the coordination of care is done by the PCP. So this is really like a big change when you're transitioning. What the take-home message here is that, again, just like, you know, all processes related to this, timing is important. You need to start early. You need to start having this conversation with your pediatrician. Like, how long will you see us, right? It's different for every practice. With your specialist, have a conversation with the child, with the individual. What are your preferences? Like, who would you like to see? Would you like to see a male provider or a female provider? What are your priorities? You know, so I think it's really important to have these conversations and engage early on. One critical need that we often, and Dr. Sharma can talk about this too, is finding primary care providers who are comfortable in the unique needs that these individuals have and are comfortable being uncomfortable, if that makes sense. We don't know all the answers. So oftentimes it could be an internist. It could be a meds-peds physician or provider. It could be a family medicine provider. The reality is, for example, developmental pediatrics, we could be managing, you know, school, behavior, medication. There might not be somebody like that in the adult world, right? So that may be split up into, say, they may need to see a psychiatrist for medication, but they also have a primary care provider. So each transition, like for each individual, is unique and it's different. But we can start earlier and we can do things to make it easier. I often tell people, one thing, it can also be hard to find somebody if an individual has a rare medical condition. It can be really hard to find an adult provider for that. And so what can happen is that you're seeing some adult providers and then you're still following up with your pediatric provider. So that transition may not be months, that may be a year or 2 years. So it's important to think about it that way. It's not just like one single event. For patients, I often tell them it's really important, thinking about your first appointment, reaching out, all of these things. The portable medical summary. So this is a 2 to 3 page document that basically it gives an overview of the key medical information for new providers for that patient. So remember, their pediatrician's been following them for 22, 21 years. Some of us have been following them for 10 to 15 years or even more. All of a sudden, they're coming to a new provider with a lot of history. And now they have to, what's current. So I think having a portable medical summary is really important, and taking time to really, put in what are their medical history, medications, allergies, the healthcare, do they have a guardian? And it's really important in the ED, when they present to the ED, that they have this document. Because also, we just take into account, well, we're going to Boston Children's, you can see everything in one, you click and you see all the specialist notes. What happens if you don't have that anymore? Now you have to tell them, oh, I have this and I have this, and I also take this. So I think having that document is really important.
That's all great points. There's a couple questions that are directed towards you, Dr. Sargato, in the Q&A, specifically about resources that may be available and links to resources if they're available online. But I want to turn to you, Dr. Sharma, because I have 2 questions that I really want to focus in on. Is one, at the very beginning of this discussion, you talked about testing and how important it is to test individuals. But one of the things that has happened in medicine is we recognize that our testing has not always brought in cultural context to testing. And so there may be some bias that happens along race ethnicity lines. And so just wondering, as we're talking about these testing efforts that are in place, are these tests considered culturally appropriate or culturally sensitive in the way that we're looking at other aspects of medicine and the testing that we do?
That's a fantastic question. And I think it's something that we're constantly talking about behind the scenes as a group, about how we can make sure that the workup that we're doing is appropriate for the children who are coming. Now, there are some assessments that are standardized, such as cognitive assessments, and it's important for them to be administered in kind of a standard way in order to compare the scores to other children who have completed that testing. There are certain nuances, though, especially if a child is not an English language speaker, if we bring in an interpreter, how that affects the validity of the study. When looking at autism specific testing, there's a lot of cultural components we need to consider. There are certain things that are considered culturally appropriate within quote unquote the American culture that are not considered appropriate, of course, across other cultures. And we are a melting pot. We are seeing very diverse groups of individuals coming in, and Dr. Sargato and I are both of different backgrounds. We appreciate the cultural nuances that go in there. There's no perfect answer to this. There's no like, oh, well, this is the version that we give for this language speaker or this person of this ethnic background, sorry. The way that we approach it is that these tests, while they're important, they are looked at. Well, after we do testing, we have a conference, and we, as a team of evaluators who perform the assessment, and we take all these things into consideration before we make our final decision as to what this diagnosis is. With a lot of the diagnoses that we're making, there's no blood test, right? There's no blood test to say, oh, you have diabetes. Oh, no, these are things that really require clinical judgment. So we try our best, and it's not a perfect system to take these things into consideration when we are making our diagnoses, but it is a work in progress. And it is a point that we talk about a lot. As you mentioned, I work with the Advocating Success for Kids program, the ASK program, and that program is really targeted towards individuals in communities that are underrepresented and underserved. So it is a point of discussion and a disparity that we're trying to address actively.
So staying in that same lane of thinking, but switching it from the health system to the patient and their families, how do we think about addressing stigma that may come along with the diagnosis? And also, how do we mitigate bias within the patient or the family's perspective?
That is part of the reason why I went into this field, because of the stigma that my own family had regarding some of these diagnoses. And I felt like that was a barrier to them accessing certain supports and services. And there can be cultural reasons for why there is stigma. There is societal reasons. There's a whole host of reasons why there are stigma, was there's stigma related to what a diagnosis is, what it means for your family, what it means for your child's future, and whether or not you access resources is directly linked to how you relate or accept the diagnosis. Because if you don't think that anything is wrong and you don't want to accept that anything is, needing improvement or needing support, you're not going to access the supports. And the person who suffers is the child who needs that support. So that I think the way that we try to, I feel free to jump in, Dr. Sargado, but the way that we try to approach this is partnering with the family, less about the name of a diagnosis. ID, autism, yes, fine, but let's talk about your child. Where do you see your child in terms of their goals and your goals for them? And what areas do you feel like they need support in now? And how can we make that support happen, regardless of what you may think your child has or what we may think your child is diagnosed with? How do we support that child? I think that's the first line to battling stigma, because whether or not we put a label on something, it's neither here nor there. It's how we're supporting the child in real time. And I think it gets a little complicated, of course, when certain, insurance companies will only pay for a service if there's a diagnostic label put on something. So there are nuances to this. It's not just a simple answer, but I think the first step is making that partnership with the family, do goal setting with the family, and making them feel like they're heard and their concerns are validated. And when they have concerns or apprehensions, finding out the root cause. Why are you so worried about this diagnosis being made? What do you know about it? And what are your concerns long term if we make this diagnosis for your child? Those are some of the ways that we approach this.
I think that also answered, sorry. I think
No,
that
no,
also
please go ahead.
answers the last question in the chat, where it's somebody had asked, how should providers appropriately and competently address families who are hesitant or even reject to pursue testing? So getting to the root cause of it, partnering with families and understanding, why are you hesitant to pursue testing? Why do you, what do you think it will show? Why is that? And I think once you get to the root cause of it, you can then engage and partner with a family to do the next steps.
And by the time they come to us, the question is, well, what brought you here? Because that's what you can partner on.
Very quickly, because I recognize that we're towards the end of our session, there was a question I wanted to address in the chat that talked about ways that we can reduce chronic diseases that were mentioned, such as obesity, mental health issues, hypertension, diabetes, etc., in individuals with intellectual disabilities. And how do we think about, those complex but more common medical issues in addition to managing care for individuals with intellectual disabilities?
I think as providers and physicians, we actually have, as part of primary care, we have, and Dr. Sharma Anchal can talk about this more, we have specific, for example, depression questionnaires that will tackle depression that we give in visits. The important thing is to recognize that these are occurring. And also talk about if you're worried, talk about these things with your provider. So dental caries are so common, right? Why do people have dental caries? Because they can't tolerate going to the dentist. But that is something that we can help you with. But sometimes if your visit is short, that may be pushed to the side. But actually, it impacts so many things. So I think bring it up to your provider and let's talk about solutions. What can we do to help you? Can we do behavior therapy? Can we do visits to this clinic when you're not always sick, so that the child doesn't think, oh, I'm going to get a shot every time I come here. So things like that.
And just one last question before we end, and I just wanted to highlight this. So we've been talking about this, again, Harvard Medical School, Boston Children's Hospital, amazing resources. not everybody has access to the same level of resources. So to you, Dr. Sharma, just a little bit more about how we can expand care for our rural patients who may be dealing with intellectual disabilities, just recognizing the complexity that may come into place there.
I think it's multifactorial. I think that we have to go back to the question that you were asking me at the towards the end earlier about bringing this up as a topic of education along the course of as people are going through their different disciplines, whether it's medical education or other. People have to be comfortable talking about these topics. People have to be comfortable engaging with individuals with these diagnoses. And I think that there are not many developmental pediatricians out there, especially in rural areas. So we need to rely on our primary care counterparts, teach them the tools to recognize early signs of some of these diagnoses, and then provide them with the tools to make appropriate referrals to send people out that may need to travel to get this official diagnosis. But then it's also, what do we do after? Going back to those rural areas where services are scant, wait lists are long, as they are in our metropolitan area. I mean, the wait lists have exploded since the time of the pandemic, and it's really hard to get them down, and it's really hard to get people the resources and supports they need. So I think it goes back to advocacy, awareness, and education, and really normalizing some of the things that are stigmatized so that so that's not a barrier to access.
So I want to close by saying thank you to both of you, Dr. Sharma and Dr. Salgado. This was a broad sweeping conversation, and your expertise in the space clearly shined through. And so thank you for walking me through everything from definitions all the way to some of these complex issues that we've discussed. We look forward to sharing more information about resources available for individuals with intellectual disabilities. So if you have additional resources that you would like us to display on our DICP website, please send those our way, and we're happy to share. For our audience, thank you for joining us. Thank you to Lynn Fulton John, who's been in the background organizing this effort, and Dr. Reed and her guidance as the Dean for Diversity and Community Partnership here at Harvard Medical School. Following this webinar, you will receive a brief survey to assess this session. We hope you will take a minute to respond to it. It is very helpful for follow-up webinars that we do, either as part twos of these webinars or as we look for different topics to include in these discussions. Also be aware that we have some other events that are going to be happening through the Office for Diversity, Inclusion, and Community Partnership that you can find out more about through our website, including a webinar that's, a future equity and social justice dialogue series that's going to be in person on geriatric care and health equity. That's going to be on May 8th. So more information to follow. Again, thank you to our panelists for being here. It was a wonderful discussion, and I hope everyone has a good rest of your day.
Thank you for having us.
Thank you.
Take care.